Hello, my name is Peter. I'm a researcher from Germany, researching food and farming. And I'm very pleased to welcome Dr. Gammampila here in Colombo to ask him a few questions. Dr. Gammampila, would you be able to introduce yourself, please?
Yes, indeed. Thanks, Peter. I'm Kamal Gammanpila. I'm a medical scientist. I got a PhD in physiology from Imperial College and Master of Philosophy from in biophysics from Brunel University, UK. And I've been working on this Sri Lankan health crisis, previously known only as kidney disease or CKDU, and but there are many other aspects to this public health crisis.
And could you explain the nature of your research and what prompted you to focus on the health of your fellow Sri Lankan people?
Yeah, right. Although I have been living in UK for a long time, in fact since 1969, I have always been in touch with Sri Lanka, or I have taken an interest in Sri Lankan matters, especially of this nature, health matters, etc. And when I came on holiday in 2013, I had the opportunity to attend the post-publication of the WHO Sri Lankan government study on CKDU.
The kidney disease.
The kidney disease, which is dominantly, or which was dominantly in north central region, or the dry zone of the Sri Lanka. So at the meeting, or the conference was terminated with the general comment that why is it in only in Rajarata, that is the north central region, and whereas we all eat the same food and we all use the same fertilizer, because there was a notion or general understanding that this was related to fertilizer. So in fact, within 3 weeks, based on the report alone, I made a presentation to the then minister in charge and said organic farming will not work, and organic farming, especially in these paddy fields and with this rice cultivation water, will not work, and I gave the reasons. And most unfortunately, up to date, Sri Lanka has not done a proper study to eliminate those, my claims, so to say.
So, what are your main conclusions from your studies and your academic research?
We can account for all our public health problems, current public health problems, which are many. Chronic kidney disease, thalassemia, where we got 500,000 cases now, and oral cancer. We are the highest in the world for oral cancer, and the youngest child or the youngest group is only 6 months old for that. And there are many others, such as anemia, malnutrition, stunting, wasting in children, so whole array of health issues. And I can, or we can, account for all those by agricultural chemicals, be it fertilizer related or weedicides and pesticides. We haven't, unfortunately, we haven't done much research on weedicides and pesticides, that is to say glyphosate and related chemicals. But we have done quite a bit of work on fertilizer related toxicants. The toxicants are arsenic, cadmium and lead.
Heavy metals.
Heavy metals. But we can explain almost all our problems with these, and so we need to address that issue most urgently. And my further finding is that we got this problem in Rajarata purely because of the rice cultivation water. Rice cultivation water originates in hill country, and that water has very small quantities of these toxins, but they become biomagnified in the paddy fields, because to harvest a kilogram of rice or paddy, you need about 5,000 liters of water. That's where the real problem lies. So the paddy or the rice in Rajarata, for example, get a dose of toxins from the local application of fertilizer and another dose from the irrigation water, which could be similar or sometimes more than from the local application of fertilizer. Furthermore, rice plant does not take up all the available toxins. Takes up about 1% or so. And that soil that takes to grow a kilogram of rice, which is about 2.5 square yards and at a depth of 14 inches, or that would be the plough depth or the root depth we can call it, in that volume you get 10 to 50,000 times arsenic, cadmium or lead than what comes out in that kilogram of rice. So I am not an agriculturist, I am not a soil scientist, but to me it seems this doesn't seem right. And it is proven in the produce. So we don't have to, in my case, or a medical scientist, medical doctor, does not have to be concerned about what's in the soil. Leave it to the experts. But they must be in the forefront to identify this is a medical question, medical problem, and say what is causing it. And then the others should remedy the soil or whatever so that the rice or our vegetables are not toxic. Most unfortunately, it doesn't seem to happen in that way in Sri Lanka.
So there would be a difference between rain-fed rice and rice that is fed by water from the hill country. Is that what you are saying?
Absolutely. We don't have this problem in southern places such as Galle, Ambalangode, Colombo area, Kegol, Jaffna, and Ampara, certain areas of Ampara, the coastal area, because in coastal area of Ampara, they have a huge reservoir. What is called Senanayaka Samudra is the deepest natural reservoir in Sri Lanka, and those who do their paddy cultivation with that water do not have this condition, and they do not have a link to the hill country water. And also they get their waters from the local mountain range, forest reservations in fact. Most unfortunately, I understand now, they have begun to cultivate those areas. Before doing that, they should pay attention to the health problem, which is far more important than any other issue in the country at all, because the way we are going about handling this issue, we will get wiped out or we will get annihilated.
And what are the obstacles you have faced in publishing or discussing your findings?
I take the view, with evidence I must say, our approach to solving this problem is completely mismanaged. And at times it may have helped politicians, because these are very difficult issues for politicians to admit to. Especially when all the politicians throughout for a very long time, I should say 50 or 60 years, we have been developing irrigation schemes that takes water from hill country to Rajarata for paddy cultivation. And the first tunnel was opened in 1976, a place called Pulgulla near Kandy. And in 1992, they identified the first cases of CKDU in Anuradhapura. That is only, how many years is that then? About 16 years after the opening of this tunnel. And what's called Minipa Canal, that is the last irrigation system commencing after the last hydropower plant in hill country. And there the water gets diverted into two schemes. One is called Minipa Canal, which is about 78 kilometers long. It goes almost up to Polonnaruwa. And the other side of the Mahaveli River, because the river runs in the middle, Minipa Canal on the left hand side, and on the right hand side, what's called Logalloya, supplying to the right hand side of the irrigation system and to a vast area. And those places too, kidney disease was identified in 2002. They opened the schemes in 1987. After about 15 years, we got the kidney disease. But I must say, in that down Winnipeg Canal, for example, in the first few villages, first village has only 4 patients, and a couple of villages down has 47 patients. These are people who are receiving benefit. In those places, nearly everyone who is ill would get benefit because they are all poor people. Only difference why one village has 47, other has 4, is the first village uses the water for paddy cultivation from the local mountain, which is not contaminated at all. Whereas the other people, those who are falling ill, that village gets water from what's called the Winnipeg Canal. So the clear indication that something in the rice cultivation water originated from hill country is the cause of this problem.
You have to follow the water.
Yes, absolutely. Rice cultivation water, not the drinking water.
The rice, tea is also grown uphill.
Absolutely. The thing is, there may be some toxins in the tea. If you use a chemical, there would be some anywhere on anything. But it depends how much it is. And if it is very small amount, I believe it is a small amount. Furthermore, the answer is this. We eat 300 grams of rice per day, average, national. If you look at the tea, say you have 10 cups of tea, 10 teaspoonsful of tea per day. Or again, you don't eat that. You take the infusion now. So some of the toxins, even if they are there, wouldn't be coming out.
And the tea is uphill.
Uphill.
And the rice downhill gets the toxins.
Toxins applied in the tea industry. I won't limit to the tea industry. There are vegetable plantations too. But the thing is, there's more tea than vegetable plantation. Perhaps you have traveled to hill country, you would notice that it is the case. But most unfortunately, those who are writing reports, for example, those who blame the vegetable farmers in the hill country for polluting the river and causing health problems in the lower areas, fail to even mention the existence or the presence of tea estates in hill country. So this is the type of people who have been helping Sri Lanka to solve this crisis. I think they have a different agenda.
I have read in your report that 62% of the people who are suffering are women and children in the case of kidney disease.
Yes.
What are the implications of that?
Implications are extremely serious, extremely serious. Now here I must say, thalassemia, I must bring into the equation thalassemia, when it comes to implication population, for example. Thalassemia is also in the same areas. Kidney disease is very high in Anuradhapura and Kurunegala, and thalassemia the highest in Kurunegala and Anuradhapura. The scale of it is unbelievable.
Could you name some numbers?
Yes, exactly. They have done a study in 2017 of school children, 15 to 17-year-old school children throughout the country. In each district, they studied 3 schools. And in Anuradhapura, thalassemia, there are various types of thalassemia. Total amount of thalassemia among the children is 23.9, and in Kurunegala, 20.7.
1 in 5.
1 in 5, and almost 1 in 4 and 1 in 5. These are unbelievable scale of disease. Now in thalassemia, with certain type, the lifespan is only about 30 years, and the median is around 70. So when you have studied 15 to 17-year-old, if you got nearly 25% cases, it goes to show that some have already died. So the number is much higher. The implication of this is we are going to run out of women to produce children. That I have begun to show, and I am in the middle of presenting my analysis to the academic community in Sri Lanka. And most tragically, what is happening is, it is the mothers who are infecting the children, the babies. And it happens while the fetus is in the womb, or the baby is in the womb. It happens because the mother, when she is exposed, she stores toxins in her bones, in her blood, in her muscle, and some will come out. What is stored goes out in the baby. One of the mechanisms is our bones are made of our mother's bones. So when that happens, what is in the bones will most certainly will come out and get deposited in the fetus. And in general, toxins in the blood, for example, both from what is coming out from the bones, actually that is in the blood and the muscles, will expose the fetus while in the womb. And when that fetus becomes an infant, she will be exposed through the mother's breast milk, and then the family diet. And when that child comes to the age of marriage or producing children, let's say 20 years as a generation, that person will have certain amount of toxin in her body. Now her child will have more toxins, we will be exposed to more toxins in the womb, and when she is born or when a child is born, that child will have more toxins in the body. And I have been able to show that when it comes to the third generation, we have begun to see now deformed children, what are called birth defects. These are physical deformed children. So unfortunately, we have, being a developing countries, our resources are limited, so to say. In the past, we clearly identified a thalassemia case of this nature only at the birth of a child with severe symptoms.
So how long would it take to mitigate the effects of this current crisis? Because you're talking about generations now.
Yep. And most unfortunately, we wouldn't be able to help some. It's guaranteed, I must say. But we need to act immediately to protect or salvage what we can and to prevent others from falling ill, because the situation is extremely serious. To address this issue, there are two parts to it. Health management is one thing. To manage health, we must prevent people being exposed to toxins, agricultural toxins. That can be done fairly easily through diet. Water may also give a certain dosage, but water alone will not cause kidney disease. That's guaranteed. I must say, from the known agents causing kidney disease, cadmium and lead. The water contributes less than, say, around 5%, the combination. So that is not going to cause kidney disease from that, but water may cause other things, but we haven't investigated. But most certainly whatever is in the water would be in the food. We know cadmium, lead, arsenic is in the water in minute quantities, but in large quantities in the food. Similarly, WHO study found that their urine has weedicide and pesticide residues. That means they are getting those into the body somehow. I would say more from the diet than water, just like with heavy metals. But most unfortunately, we haven't studied those. But for the moment, we certainly can account for the thalassemia and kidney disease with heavy metals.
So it would mean we would have to stop the application of the chemical fertilizers right now in a moratorium.
Absolutely, absolutely. And we cannot use or clean up soil in the endemic areas without addressing the issues in hill country. Because as I was saying earlier, it is that rice cultivation water that provides an extra dose. That is what it is. In other areas where there is no CKDU or these diseases at the moment, maybe one day it will happen.
So you could even see that you have areas with the hill country water and areas with the rain-fed water displaying different number of cases.
Absolutely, absolutely. I mentioned the Winnipeg Canal, and by the way, I have visited all these places. And there's a river called Hinganga that is near Hettipulla, perhaps you are aware, and the river originates in Knuckles area. We don't have kidney disease in Knuckles because there are no reservoirs, all rainwater. But along that river, We traveled along the river until the last kilometer, no kidney patients. In the final village, we came across 2 kidney patients, 2 brothers. One does the rice cultivation with the Hinganga waters, and the brother with the Winnipeg Canal waters. And their demarcation is only the width of the Winnipeg Canal. In fact, the Hinganga goes under the Winnipeg Canal through to the paddy fields. And in that area, perhaps in that particular paddy field that gets Hinganga water in combination with Winnipeg Canal, perhaps there are no kidney patients maybe. But everyone else along Winnipeg Canal, every village, for example, has kidney patients. And a place called Girandurakote, that is where the main hospital is, some of the areas are identified by the hospital, had over 20% CKDU patients in the WHO study. And we haven't addressed it meaningfully up to now. And in that area, Girandurakote area, we see the early type of thalassemia. And in those areas, I would say in 2027, that's the commencement of 3rd generation. With that, we will begin to see severe cases of birth defects, stillbirths, underweight, and all that. So some things are predictable now. We know it. So we need to act immediately. We may be able to salvage those people.
Dr. Gammanpila, thank you very much for this interview.
My pleasure. Thank you very much for giving me the opportunity to air my thoughts.